Hi, good afternoon. My name is Jesus Morales, and I'm a social work graduate student at the Mexico State University. Today, I'm talking about Mr. A, who's my client. So, really quick about myself is I'm a veteran, post 9/11. I've had 3 tours of duty of Operation Iraqi Freedom, Operation Enduring Freedom, and Operation New Dawn. And my areas of interest is I would love to work with veterans in the near future. I feel that I'm obligated to give back to the military because it gave me so much and allowed me the opportunity to be here. So Mr. A is a client for our program in the ambulatory care sensitive conditions program because of his uncontrolled diabetes. So what we're going to do is we're going to help him connections of service with the VA and use a holistic approach to work with him on all sides of everything that he needs that we can do. And help improve the quality of his life. So one ethical dilemma that I faced when I was working with Mr. A was when I was talking to him, had the chance to talk to him a few times, he let it slip out to where he was taking care of his mother who was bedridden. So when I stopped the case, my supervisor, she let me know, well, how is he maintaining her needs because she's bedridden and he's been hospitalized a few times. Who's watching her when he's in the hospital or he's out doing his appointments? And he's mentioned that he has no social support and it's just by himself. So thinking about our ethical standards of privacy and confidentiality, we have to break it when it's someone's in danger or if there's a serious or foreseeable imminent threat to a client or someone else, which is in this case his mother. As far as the ethical principles go in hand, yes, dignity and self-worth of a person, self-determination, autonomy. Mr. A wants to be private, doesn't want us to know about his mother. That's personal. But going into social justice, that we had to advocate for others who cannot advocate for themselves, which is his mother being bedridden, and she cannot let someone know that she's being mistreated or she's bedridden. So who's speaking up for her? And that's where we'd come in. Integrity, letting them know, Mr. A, know that what we do is for the best interest for him and for others, and which is his mother. And competence is where we're mandated reporters to report not only child abuse, but adult abuse. In this case, we'd have to call EPS. Using the dog off model is the present problem at hand is that Mr. A is at home with his mother and he needs a house. He was hospitalized, so who's watching his mother? Who's going to be involved in this would be myself and my supervisor, so I can give guidance to, or she can give guidance towards me. The values that are in this case is, Mr. A wants privacy, but coinciding with our social work values is that we have to protect others, regardless if she's not a veteran, she still needs to be advocated for, and that's what we do because she can't advocate for herself. The objectives for this is hopefully we get a plan. Maybe we'd have a plan for Mr. A to call somebody, hopefully to watch his mother when he's not there, going to appointments or going to the store, because she'd be left unattended. That's the plan. Hopefully we could get some social support, maybe a neighbor, a friend, or someone that could go there and watch over her while he's out of the house. Alternate interventions, having to call EPS, or overall long-term goal, maybe he might have to start thinking about placing his mother in a foster care, a nursing home. So what happens though if we couldn't get this, the implementation and the consequences? Well, the mother can be neglected, she might lose her life. Mr. A might be hospitalized, and who's watching his mother? So one of the biggest things that my supervisor told me is always veer on the side of safety, because you have protection of life and also to protect your license. No one wants to go home worrying about a life. So that's what helped me make the decision to call APS. Luckily, he had already made the decision to go ahead and put his mother into a nursing home, which, that fortunately had happened. Going into competency 2 and going into competency talking about engaging in diversity, using the intersectional approach. Mr. A is a male, he's Caucasian, he's a Vietnam veteran, he's disabled, and he's elderly, or to refer to as geriatric. So if you look at this back in the history of Vietnam, when veterans were coming back from the Vietnam War, there was no social support. a lot of historical oppression. There's they weren't welcome with open arms, just like World War II veterans come. Big parades were happening, but no, they come back and they didn't have anything to come back to. There was no transitional programs. There was no VA support, medical, educational, everything that we have right now that veterans getting out of active duty and to transition to civilian. They have that, and back then they didn't. So there's a lot of historical oppression too, and I could tell when I was speaking to Mr. A. So, how do we address these in forms of social justice for micro, meso, and macro levels? Micro, working with veterans, letting them know that there's our veterans here, because I'm a young social worker. People see me as, I'm just this naive kid that just comes out of college and he knows everything and he doesn't know what it's like to, well, actually, I am a veteran itself and I don't know what it feels like to come out of Vietnam veteran, but I do have a sense of working with veterans. I'm a veteran myself and I do understand some of the things that you're going through. So tell me about them, letting them know that there's veterans that work here. Would you like to speak to a veteran social worker? And let them know the services that they could help out too. Engaging them with the VA. There's veterans just like yourself, Mr. A, that you could come and help out by volunteering here and making a change as well yourself. Meso, community providers. The VA doesn't want the veterans to have to wait for long lines, and access to medical care is a big social issue. So what we do is that the VA extends their reach and they push community providers out there that are VA approved, and they know they work with veterans, and to let them know that if you can't get the care here because of long wait times, there's a long drive, you and your VA choice to go to have your community doctors, community PCPs, and your specialty cares that are VA approved, so that you won't have to. So extending the reach of care, and macro to there's certain programs in the VA that are specific generational generation, like this program just for post 9/11s or just specific. But now the VA is addressing that by opening them all to all veteran parents. Like, for instance, the caregiver program is just for post 9/11 veterans, but there's veterans that also need caregivers from all different eras. So going out this year, that they're going to extend that policy to all veterans and different eras, regardless of post 9/11 or not. And all this is to mend broken relationships with the VA, and going into myself coming to VA, they would think that, you're just like everybody else and you want to help. Why? Because there was no social support back then, and they feel that there's no social support now. So just aware that there's that historical oppression that lies, and it's not taking it personal. And I would often, for self-regulating, I would also reflect on my day, like, what can I have done better that day? How can I approach Mr. A this way? When I talked to him about this, he didn't want to talk about just a lot of reflection, and not taking so much personal, and also seeking supervision from my supervisor, so she could, advise me or direct me in the right direction or trying different methods. And moving on to competency 3 with advancing human rights and social economic justice, environmental justice. One of the biggest misconceptions is people think that the military are well taken care of, and the vets, when they get out, they have all these services available to them, and they don't understand why. Well, that gap, there's that bridge from active duty to a civilian side, that there's just sometimes they fall within the cracks, and this leads to poor transitioning from the active duty to civilian side. Homelessness, they're not available, the resources are available to them, access to mental health, they're unaware of that, because everything's basically self-sustaining in the military, but they're so trained in the military, they don't know what's going on in the outside world, how to access that. And one of the biggest things as well too is unemployment rates are high, and actually how to access the adequate healthcare or the lack thereof. So the VA is very self-sustaining, but also requires the help of the community. So they're very important with a bunch of community resources that are veteran-centered, so they could to assist with that. And so how do we work with this in the individual level to address these issues? So the VA in my section, in my department, we do a holistic approach on our post-needs assessment that not just covers why they're there because of the, say, Mr. A diabetes, but also to what's going on, and do you have access? How do you get your appointments? How do you get to, do you have adequate housing? So we address that, and if there's issues in different areas of their life, we do warm handoffs, we get with other departments within the VA, and we let them know what's going on. But in this case, Mr. A, he couldn't access the VA because of mobility issues. because of being disabled and his amputation in his toe. So what I would do is reach out to his doctor and say, I think Mr. A would be a prime candidate for the LIFT program. Can I sign off on that for him? Because it's an actual signature needed by the primary provider for that program, and they would go ahead and do it. But the VA, the master social workers, have that ability to do that. We're advocating, talking with the PCPs, like, hey, Mr. A would benefit. Can we get him an OT, PT consult for occupational therapy or physical therapy? And they could sign off on that because they see us as eyes, extra eyes for the veteran. So one of the biggest mobility issues too is us reaching out to other services so that they could assist him with the VA transportation to get him there, or the Sun Metro Lift program, which I actually ended up filling an application for him when he inquired about it. And I'm doing that just so that we could address that barrier for him, and he feels like he's not getting adequate help, advising them on patient advocate so they could advocate for him, saying, if you feel like you're not receiving the service or being discriminated against, these are the services for you. We could fight that fight for you on this side, and we could talk to the doctors, and also to you have that option of going down to patient advocates so they could address your concerns. And the system, how do we do this in the system level? Well, the VA also holds town hall meetings, not just for veterans, but for the staff, and they could address their problems. So, I'm having can't get access to the VA. There are long wait lines. It's just, this needs to be helped. And we could do the same thing as well as staff members to go to these town halls and say, a lot of our veterans are falling through the cracks. We need better services for them from transitioning, or the VA transportation is too booked up. I think we need to have more people, hired there in that department so they could have more services. And also too, and not only just in the VA side, but in the community, the Stephen Cohen mental health clinic services veterans and families there, and they're right now doing this El Paso needs assessment, and we're advocating, since we're partners with them and it's a VA trusted agency, we let the veterans know, hey, go to this website and let them know what you need, and not just here but in the community. If there's resources that you need that are not helping or they're lacking of, let them know, and they could advocate on both sides, and we could help advocate for them. And me being a veteran, I could do the best of both worlds, advocate for my patients from the VA town halls, and also fill out the El Paso needs assessment, knowing what's not out there and the barriers that they're facing. So I kind of have the best of both worlds to advocate for Mr. A, to help him get the LIFT application signed for the primary care to sign off on it, and also to me advocating for VA transportation to be able to pick up Mr. A, so he has that, and also to inform him of the resources out there and letting him know how to advocate for himself, be it for the VA side and also for the community side. So moving on to competency 4 and talking about these research articles, I found one on diabetic self-management education incorporated with motivational interviewing, and this design was a qualitative design with a pre-test, post-test, and then a follow-up afterwards. It consisted of 4 sessions, 1 session each month, and incorporated emotional interviewing in each session. So one of the strengths is that since it's measuring A1Cs, which is in the blood sugar, A1Cs usually have a lifespan of 120 days. We could tell the history of the blood cells in there, and this program was 4 months. So it was a perfect way to measure the length, because of the length of the study. One of the limitations when you measure A1Cs, it varies from there's targeted A1Cs from age groups and personnel, so it differs. So it's not a generalizable study to focus on. But one of the during this design, this study, they were offering they were incorporating the motivational interviewing through with change talk, creating discrepancies, reinforcing positive attitudes, and also listening for opportunities to affirm each other's personal strengths and values. And so what this did was, during the study, they found out that the A1 decreased. In the beginning, it averaged between 8.23, and at the very end of it, it dropped down to the 7.32. And then 2 months later, when they did the follow-up, it dropped down even more to 7.00 for an average. And that's, normal A1Cs are from 4 to 6, and score were elevated from 7 to 9. So it wasn't a significant decrease. How does this apply to Mr. A? Well, Mr. A was enrolled into the MOOC program, which is considered diabetic self-management educational course. And they advocate the facilitators use motivational interviewing. So this would help improve his results when his A1Cs, because his sugars were elevated when he was admitted to the hospital, but also to mainly focus on compliance. That's when the motivational interviewing comes into. So because he had a bad history of compliance. My second research article had to do with patient and why the patients and why they did not attend their diabetic self-management courses. So this was a qualitative study. It was 15 participants who stopped participating and stopped coming, and they wanted to figure out why. Why was a factor for that? And the age range from 30 to 76, from 30 years old to 76. What they did was they used telephone interviews to figure out what was going on and why did they stop. So the strength was focused on why. What was going on in your life. So maybe they could try to adjust their programs, but the limitation is that everyone has this different reasons to why they don't go. So it's not, to find a very exact pinpoint right there. So that was kind of one of the limitations. But one of the findings were that there was two different themes. It was individual and organizational themes. For the individual themes, there was it was an individual illnesses. So if they say they couldn't go because, well, they were sick, they didn't feel so well, or they had a sore throat or something like that, or they had these perceived beliefs that they didn't benefit from that because they felt that they were taking up a space for them and it wasn't for them. Like, I'm not that, my diabetes are not bad. If I go into this program, then I'm going to be pushing somebody out that deserves it. And the organizational is that the duration was too long. So when they were doing the program, it was every day. It was once or twice a week, and they were at 6.5 hours long. So that takes up a big chunk of their day, and it starts affecting them financially because they're not at work. So fast forwarding to ours, to the MOVE program at the VA, it's 8 to 12 weeks. It's there's ways to go on that about it as far as you could even go to the morning or in the afternoon. So there's options there. And for Mr. A, we would help them alleviate those barriers. So taking, for instance, the why you couldn't go because of personal illness and using motivational interviewing to let him know that, hey, Mr. A, why didn't you come? What's going on? Tell me about it. Why I didn't feel sick? I didn't feel so well. I felt kind of sick. Well, we have a walk-in. You could come into the VA and kill two birds with one stone. So you could come to your program and also use a walk-in policy. So we'd help fight those barriers and promote the MOVE program through motivational interviewing and to also use a holistic approach. Why couldn't you come? Let's figure out those barriers. So one of the policies I'm going to talk about is a hospital readmissions reduction program, and this falls under the federal policy of the Affordable Care Act. So what the hospital readmissions reduction program does was it penalizes hospitals for Medicare reimbursements for 30-day readmissions. So say if a veteran or a patient or client goes into a hospital and they receive care for an ambulatory care sensitive conditions such as type 2 diabetes, CHF, chronic heart failure, pneumonia, all these conditions that fall under that category. If they get discharged and they come back within 30 days, then they get penalized. So what's good about this program is this is where our program, the ACSC high risk case management program where I was in with the VA stems from. This was created for this reason. And the good thing about this is that it holds this program, this act holds hospitals accountable for their care that they give the veterans. So if they have poor discharging, they get penalized for that. So what makes them make sure that there's good quality care and adequate discharge plans for the veteran so they don't come back. And it also allows us to go into the veterans and to do our program introduction and engagement services. The con is that the veterans compliance. So regardless if you have all this care for them and they don't comply, then it doesn't really matter. So that's where we come in and hopefully get engagement in those services and other services they may need or care with the VA. And also another con too for this program is that access to specialty care. So say this veteran gets out with diabetes like Mr. A, and he needs to speak to an endocrinologist, or he has a heart problem, he needs to speak to a cardiologist, and they have long wait times. It creates these gaps for their care for that reason. So what I would change for this policy is for PCPs or primary care, if they know that they're high risk, for them, the PCPs, to engage with us and get inserts with us, just so that they don't go to the hospital. So not a hospital, you could get to it, prevent that, and be proactive with that. Another policy too that affects our veterans, that I think it's a great policy, is the Mission Act. And it's a federal policy. It's enacted by the current president right now. It's enacted in June 2018. And what it does is allow veterans to go receive community care, urgent care, which are, urgent cares are all over the city. And they're just to alleviate from people from going to the hospital for non-serious related illnesses. The pros to this is that it's available, so it's more convenient for veterans to go seek care if it's closer. See if there's urgent care near their neighborhood, and it's VA approved, and then they could go there instead of going to emergency rooms to alleviate that. To alleviate ER visits, and it also makes it more available and more convenient to the veterans. One of the cons is only for non-serious related illnesses, like say strep throat or flu or things like that, and they're not so much VA oriented. They're not veteran oriented. They're for the community, and they also don't have access to the veterans' medical health records. So we have those. So what I would change is I would increase the VA approved community care throughout the community, so it extends their reach throughout the city. So there's a veteran that lives in, say, the Lower Valley, and there's a community care that's on the west side that's approved by the VA. That's a far drive. So if there's one in the Lower Valley or one on the east side, it makes it more available for care. And also too, with the consent of the veteran, for them to share information. So after the patient discharges, with the due to HIPAA compliance laws, if the veteran consents to it, they could share it, because we don't get that information as a veteran comes into the VA physically and drops it off. So that's what I would change as well. Increase potential biases while working with the veterans at the VA is that I feel that sometimes a lot of veterans are there just to scam the VA into paying out compensation. And the reason why I have this personal bias is that I've been in these groups from previous employers and engaging with previous veterans outside of the VA, and they school each other and they try to show them what to say, certain things to say to their doctors, and teach each other how to do that so they could get increase their benefits. So I had this bias going in there, and Mr. A blatantly asked me during time of engaging with him, like, can you put this on my record? He would just blatantly ask me, and I would have to tell him, like, and those feelings would come up, like frustration and upset. But this is not what we do. And then he would say that, we're not here to help me. And I get even more frustrated because I feel that that's wasted manpower. Are veterans here to get help, or they're here to scam the system, or they're here for personal gain? And that's how I'd feel. And how would this impact me as far as going for care? So Mr. A would do that. I would feel like I wouldn't want go above and beyond in his care, calling him more frequently and doing that, than what I did with working with him. So how would I do this with continuing learning? With educating myself on the resources that the VA has. So if Mr. A would come up to me and ask me, well, I need to do this for my compensation, let him know that this is not my scope of practice, but let me point you in the right direction to these resources available to you, the claims and benefits. The VA Texas Veterans Workforce Commission could help you with that. And by letting them know, like, I could help you get in contact with them and doing a warrant handoff. So the plan is for me to let them know once veterans come into my program, let them know what we do, what we don't do, and if we can assist you, we could point you in the right direction. And for myself to know that not all veterans think like this. It's not a generalizable assumption of all veterans that they try to scam the system. That's not the way things work, So I could handle every case is unique, and even still not have my personal biases reflect and impede on the care that I'm giving them. And if I still have issues with that, then I could ask for supervision, let them know what's going on, ask for other supervision from veteran social workers, and how do they deal with this, if this has ever been a factor for them, and how did they cope with it, or how did they go about them, type of training, type of education that they did, or they know it passed on to me. And also too, sticking to the basics, reverting back to the code of ethics. Just because I'm a master social worker doesn't mean I still need to go back to the NSAW to refresh myself for that.
And, and it's great guidance right there. It's kind of like our Bible to us, the NSA Code of Ethics, because that's who our license is, and that's how we practice by that. And just sticking to the basics. So for competency 7, we're going to go ahead and use the ambulatory care sensitive conditions post-hospital needs assessment, because that's a baseline, the assessment that we used to figure out the overall care, and not just for the care for him, but overall needs in general. So the primary reason why Mr. A was hospitalized because he has said that there was a rash on his foot, on his toe, and it was spreading really quickly, and that's the reason why he went to the emergency room at William Beaumont Army Medical Center. There were 2 quarter-sized sores on his foot. The chart said there was appears to be wet gangrene and possible underlying osteomyelitis, which is an infection in the bone. When he also went there, his blood sugars were over 600, which is very concerning, and his weight too was at 305. Primary admitting diagnosis when he went to the hospital was DM foot, which is the diabetes mellitus foot, which is the source. Secondary diagnosis was uncontrolled diabetes type 2, which is what we're going to focus on. During the assessment, Mr. A reported that as far as cognitive function, he has no trouble remembering. He has good vision. He just uses reading glasses approved by the VA provided for him. He was able to verbalize his needs and wants. His hearing was good. He reports to not using any hearing aids. He's able to complete all his ADLs independently without assistance. Very independent. As far as occupational and therapy and physical therapy, reports to not having any. DME and supplies, so durable medical equipment, which is he does use a cane, but only when it's necessary. He doesn't use it very often, and he does have shower bars in the shower to assist him getting in and out of the shower. As far as peer and social support, he has a 12-year-old son that he shares custody with, that comes with him on weekends from his ex-wife. He doesn't have really much friends. He's a real homebody type person because mainly he has his mother to look after, who's also staying with him because she has medical needs as well. Social history, family history. He's had 2 older brothers that passed away due to a heroin addiction, and he has 3 dogs. Transportation, Mr. A said that he's able to drive himself sometimes because of his issue with his foot. It's hard for him to drive because of the pain, and he wishes that there were spaces available for him to park closer to, because he doesn't have a placard for that, for disability parking placard. Financially, he does receive his railroad pension, and he is receiving VA service-connected disability from the VA. So he doesn't have any issues paying any bills. Emotional behavior support. Mr. Abel was alert. He was focused. He was very cooperative during the time when I called him. He was goal-directed. His speech was clear. While modulating rhythm and normal way to rhythm. He denied any current suicidal ideations, although he did stress that he does have a history of suicide thoughts. They come and go, but when they do come, he said he's able to get up and just change where he's at, like kind of a coping mechanism, and just to get that mind out of his mind. He says that he would never act on him because he has a 12-year-old son he needs to support, and he has his mother he needs to take care of. So he has a protective factor right there. He did not to be in any state of distress when I was speaking to him. When I was talking to him, I did offer him the William Beaumont Suicide Army Medical resources, the Emergency Crisis Hotline, and also to the VA mental health walk-in policy. Mr. A does have a diagnosis of MDD, of major depressive disorder, is currently recurrent and partial readmission. Mr. A's spiritual beliefs is he is Lutheran, but he does want to start exploring the Catholic religion. But he says after he gets out of it, everything starts going well with his health, that he wants to start looking into that. He feels safe at home. He doesn't feel like in danger. He does have 3 dogs for his safety, and he is navigating around his house. Medical literacy, Mr. A doesn't understand that the medicines he's taking really so much. He knows he has to take them, but he doesn't know what they're for. He knows it's just for diabetes, and that's all. So he's unaware of what he's taking. He does have a will in place, and some of the other needs that are identified was what he said is like he doesn't have a disability parking placard, so he could park close. So we're going to go ahead and look into that. And there's no other agency that's involved in this care right now other than the VA. So the needs identified was that, we're going to get him enrolled into the diabetic self-management program, which is the MOVE program, telehealth to assist with his high blood sugars and to monitor that, and Farm D for medical literacy. And we're also going to look into getting him a parking placard due to his disability with his foot, his amputated foot, and also to engage him with a chaplain. The plan is, like I said, the ambulatory care program he's enrolled in. He knows the obligations for it and what it concerns. We're going to monitor him for the next 3 months and call him every 30 days or if necessary. Refer him to the MOVE program, refer him to telehealth, and refer him to Farm D for medical literacy. And we're going to look into transportation mobility resources such as the parking placard, a transport lift, and other resources that I was able to provide for him today was the nurses hotline for the Mission Care Act. As far as to him, his availability is to call them for urgent care if need to, so you don't have to come to the emergency room. The crisis hotline, the William Bowman Army Medical Center, and mental health due to if he ever has any suicidal ideations or thoughts, who he could call for that. Looking into a theories approach, ecological systems theory is when I look into him and I see Mr. A. All these other contributing factors that could help out with improve his quality of health. Policy, the hospital readmissions reduction program, the Mission Act. Those are all type policies that are affecting him because that's where our programs is from the AHRP, from the Affordable Care Act, and the Mission Act to help him with more adequate available resources as urgent care community. We're going to also, to if necessary, get him in touch with VA outside care, just in case there's a long wait time, so he could have those resources available too. Resources as far as transportation, the Sun Metro lift, the VA lift, the VA transport, and also to get him that disability placard for that reason, to help with that issue. Organization involved is the VA. The VA and the telehealth, the MOVE, all those are programs within the VA organization. And interpersonal, Mr. A was able to move his mother into a nursing home. So that's going to help out because he's able to focus more on his personal self and his diabetes needs. An overall goal for this is to improve his quality of life and health. So in regards to a competency and interventions, some of the interventions I'm going to use while working with Mr. A is main ones are going to be diabetes self-management education, and the MOVE program is one of these DSME programs. So what the MOVE program is, it's an 8 to 12 week program, and what they do is they bring in veterans, all different ages and all different, and it's focused on every single veteran at the VA, regardless of war era. So they bring in a social worker through, social worker runs it. He's a licensed clinical social worker, and he facilitates it. And then throughout the time, they bring in a nutritionist and they talk to him about eating habits and weight management and healthy eating habits and healthy weight and not fat and crash diets and things like that. And other health specialists will come in and talk to them the duration of that to get them educated on their diabetes and how to manage it properly. Also to telehealth. Now telehealth is going to help monitor his sugar levels. And what they do is we sent over at the expense of the VA, a monitoring system there. He registers it and it sends a signal to the VA and it goes into his chart, what his blood pressure is right every time he registers it. And if there's an issue, if it's too high or he's not registering at all, then a nurse will call him and intervene and assist him with that. What's going on, or why didn't you register, and what can we do, or advise him, hey, they're too high, what are you eating, or Farm D is also true. We're going to use is a pharmacist that will get in contact with him about medication management, what medications are you using, how to use them, their information on them, or is it working, is it not working, how can we tweak this for you, or and also to the chaplain. Mr. A spoke about, he was exploring, the Catholic religion. He wanted to know something more about that. So we're going to get him in contact with the chaplain and also too with primary care mental health integration for his mental health needs if there's ever if they're needed. And one of the main ones too is motivational interviewing, because Mr. A does have a history of non-compliance with his care. That's where we come in through the social worker at MOVE and myself when I speak to him to keep him from slipping or from falling off track, but to keep him going for compliance and throughout the program. and also case managing our services. So I would call him every so often, but since I'm an intern, I could call him more frequently and to address any new concerns, not just because of diabetes, but if there's something else that we could assist him with and bridge that gap with him in services. So the overall goal is to improve diabetes management with the interventions that are evidence-based by the ADA approved American Diabetes Association for the MOVE program, and motivational interview that's also evidence-based approved by the Paso VA. So the overall goal is improve diabetes management. How are we going to do that? Well, we're going to get assisted with telehealth, and they're going to register his glucose. He's going to register it every three times a day, before meals and before bedtime, because this is something that's necessary. And also to attend the MOVE program once a week for 8 to 12 weeks, the duration of the program. And we're going to monitor this through the CPRS system to see, is he going, is he registering, and when do we need to intervene? Did he not go, and why did he not go, and why is he not registering his glucose through telehealth? And the plan is, if he's not doing this, we'll intervene, we'll give him a call. If he needs to speak to somebody else, we'll reach him out, we'll give him a warm handoff, to the other interdisciplinary professionals. We're going to track his health through the CPRS system and intervene when necessary and follow up when we need to. And this is all going to increase his likelihood of success, which is diabetes management and compliance with his care. So going into evaluating practice, so how was I able to see if Mr. A was meeting his goals? So I would go into the CPRS system, which is a computerized patient's record system. And it's how we track the veteran and their care. If they're making their appointments, did they not show, what's going on, notes from the doctor. But we're able to see if Mr. A is going to a MOVE program and he is registering his glucose levels through telehealth. So I created this chart to show his progress and where he may have slipped. So throughout the months, he was going to the MOVE program, he was in telehealth, but right here in August, towards the end of August, he didn't make one appointment. So I reached out to him and said, hey, what happened? And he's like, you know what, I had to move that day, my mother into an actual nursing home. And I know that's something that that was affecting him, and also too, as far as the ethical dilemma that we had. But he ended up doing that, which is understandable. So he was going to continue. He did register for telehealth right there. So he was continuing with his treatment and his goals, and he was making them. But towards the end right here of November, towards the end of our program with us, he stopped going to a MOVE program. He stopped registering his glucose through telehealth. When I reached out to him, I tried to figure out what's going on. How can we, what can we do for you to get you back going with your care? And unfortunately, his mother had passed away. So just through uncontrolled factors, this happened, and it did affect his care. So how do we know they're being met? By monitoring his care through CPRS. We were able to see what the nurse was doing, how she was intervening. We were intervening. What can we do? He also mentioned too about there was too many appointments. So we could change that for him. So how can we go to where your appointments we could stagger them for you? Let's talk about that. Let's spread them out because of care fatigue is back to back to back. He was in bad shape, but he was complying. He was going to them, but he just stressed. He was just feeling overwhelmed with them. So we'd intervene. We modified that by spacing his actual appointments for him. And also too, I called him frequently to see how he's doing, because I actually had that flexibility to make more frequent calls to him because of my caseload, and to see how he's doing, what's changing. When I was talking to him, there was increased health behaviors and activities, because he did get a smartwatch to use a pedometer with that smartwatch to track what he's doing, how, his walking, his workouts. So that was good. That was a good behavioral change. And what else did he do? He was keeping his appointments. Even though we had to stagger him, he was doing that. And he wasn't doing that before because he had a big history of non-compliance. And when he didn't want to do something, he would ask me, can you call the nurse and let her know what's going on? Well, then we would do this in an empowering moment where we tell him, well, I'm going to let the nurse know that you're about to call her. You're doing so well, not to discredit everything that you've been doing. Let's continue that. You're doing a great job right now. By taking control of your health, and let's continue that. So you give her a call, but I'm going to let her know that you're about to call her. So we have to empower our veterans and not enable them. And also due to the uncontrolled factors that he did end up dropping out. but not due to no fault of our own or what we did, because, you know, at first I thought that because of his MDD, of his major depressive disorder, that he was experiencing an episode, but we have to think about differential diagnoses. His mother just passed away, so it could be bereavement period. So what do we do for that? I could do a GAD-7 or a PHQ-9 assessment and get in contact with PCMHI, which is a primary care mental health integration, and social worker there, and do a warm handoff them so they could seek services for maybe mental health or to assist them in that time of need.